everyone. Welcome back to all my listeners. Now, if it's your first time finding me, thanks so much and welcome. Welcome to my 16th episode of Season 5. Today is Wednesday, April 20th, 2022. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, I hope everyone had a really nice holiday weekend. It was Easter on Sunday, so I hope you went Easter egg hunting, enjoyed some chocolate bunnies. I know I did. But on the flip side of my weekend, I also had to file my taxes. Yes, I'll be getting a federal refund in a couple of weeks, but my state taxes for Illinois, I did owe some money. So, of course, I waited till the last minute to file. But anyway, that deed is done, thank goodness. So, why don't I get into our episode today? I want to get us back to basics on something I can't believe I haven't touched on in all of these episodes. I want to get us back to basics on Incident 2 billing. It's still a problem. And everywhere I look, there is just news galore in the US. So I'm going to be diving into my popular Newsworthy Grab Bag session. And I go ahead and close out today's episode with some inspirational words on clarity and focus from Melinda Gates. If you checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss another episode. Please write in a review and kindly drop me a 5-star rating on Apple Podcasts or wherever you listen to my podcast. I'd really love your support. And as always, a friendly disclaimer. Remember, I'm bringing you the news, current healthcare industry news, my compliance tips and recommendations based on my over 10 years of experience in front office, back end, coding, and billing for multi-specialty physicians, compliance, and auditing for both E&M and surgical operative reports. These are my opinions alone and are not to be construed as legal advice. So let's get into Newsworthy. I'm excited for this grab bag feature. Now first, just in case you missed it, the public health emergency, the PHE, has been extended once again in the United States. This is the 9th extension to date. Now, this particular notice was made effective on April 16th, 2022. That was just a few days ago, and it will remain in place for 90 days. Now let's move on to my second grab bag feature. Along that same note of the PHE, just before the PHE extension, there were whispers, right, in our industry. Whispers of what's going to go on with telehealth. Like if the PHE ends, what will happen to telehealth? Or if the PHE stays active, what will happen again to telehealth? Now, the Center for Connected Health Policy highlighted some of our burning questions and provides some really good, useful information. Now, remember, even if the PHE had ended on April 16th, a few days ago, the Consolidated Appropriations Act of 2022 extended many of the COVID-19 flexibilities for 151 days after the PHE expires. So remember, these are things that will stay permanently in the United States. Now, in terms of Medicare, the Medicare reimbursement for eligible telehealth services when the patient is located in a geographically rural area and in an eligible originating site. Now, in most cases, this is not the patient's home. Now, for Medicare reimbursement for mental health telehealth services, which will include audio-only services in some cases, that will be provided so long there's an in-person visit within the first 6 months of an initial telehealth visit and every 12 months thereafter. So it's important that that in-person visit with the provider is established. Now, implementation of this particular in-person requirement is delayed for 151 days. So keep that in mind. Now, there will be Medicare reimbursement to federally qualified health centers and rural health clinics, although the billing for this will not be the same as telehealth specifically. Now, CMS has redefined a mental health visit to now include encounters that are furnished through interactive, real time telecommunications technology, which will also include audio only delivery in some specific cases for a mental health disorder. Now, what will stay on for a temporary basis? Again, that's that 151 days, but will go away after that, right? So it will be allowed for 151 days, but thereafter, on day 152 and on, it will be terminated. So, some examples of that include the Medicare reimbursement for telehealth services provided to patients at home, Medicare reimbursement for an expanded list of eligible providers, for example, occupational therapists or physical therapists or speech language pathologists and audiologists. And then the Medicare coverage of audio only telehealth for non mental health services. That will also go away after day 152 and beyond. Then also reimbursement of our federally qualified health centers and rural health centers as distant site telehealth providers for non-mental health services. Now, as I stated earlier, those FQHCs and RHCs will continue to be reimbursed for interactive, real-time telecommunications technology for a mental health disorder, which means it has to be that two-way audio and video capability, functionality. Now, what will be eliminated right away, right? If the PHE is actually over in 90 days, let's say, for example, it might end in the middle of summer, right? In July. Let's see. So what will go right away is reimbursement of some of the Medicare telehealth services. Those will be expired as soon as that PHE ends, such as, this is really good to note in our time of mental health crisis, right? What will end is the group psychotherapy and telephone only E&M codes with our 99441 through 99443. Now remember, those particular telephone only phone calls were never reimbursable for Medicare pre-COVID times. So let's keep that in mind. This was a big bonus that we all received during this PHE. So for them to go away is not really a big deal since we never actually had them to begin with in pre-COVID times. Now, the others that have been extended through the end of 2023, like I said before, some of those occupational and physical therapy service codes, some of our emergency department visits, and some of our nursing facility discharge days. Now, CMS website provides you a great list, so try and hop on their website. They provide you a great list of telehealth services for exact CPT coding. Now, during this particular PHE, providers were able, if you remember, to prescribe controlled substances without an in-person examination. Now, you could never do that pre-COVID. So during the PHE, providers were able to, with the flexibilities, with the waivers, they were able to prescribe controlled substances without an in-person exam. Now, this particular flexibility, this waiver, will expire with the end of the PHE, which will require our providers to go back to the old strict rules. And in most cases, this will require a patient to be located in the doctor's office or the hospital, registered with the DEA to be prescribed a controlled substance via telehealth. So that DEA regulation will kick back in force again once the PHE is officially over. Now, some of these things that we're all not quite sure about as of right now, some issues that change are going to be from state to state, right? Those things are going to be very fluid. So you have to look at your state regulations, what's going on. Then you also have to look for all the changes in your private payers and in Medicaid, right? If those are in your payer mix, because that will all vary as well from Medicare. Those will all vary from Medicare. Now, during the COVID-19 PHE, right, the office for civil rights, the OCR applied enforcement discretion to our telehealth providers, right? There was a big flexibility, which allowed them to utilize any non-public facing remote communication product, even if they don't fully comply with the requirements of the Health Insurance Portability and Accountability Act of 1996. That's HIPAA, right? So they could use anything like FaceTime, right? FaceTime isn't technically approved by the OCR in a pre-COVID timeframe, but it's allowed. So since this particular decision was made, the OCR has the ability to keep this policy and allow it to expire when the PHE ends. Now, of course, we have to look at our state-based policies, right? And those will all vary depending on the end of a given state's public health emergency status, right? Or what is their state of emergency today? And they may or may not be tied to the end of the federal public health emergency. So that's where things get complicated, and you have to dive deep into what's going on in the state that you reside in. Now, policies that fall under state jurisdiction include Medicaid, right? All of the private payer insurance as well, and those waivers that allowed out of state licensed providers to practice within a given state due to the emergency circumstances. So, all of those things will change as well, and probably already have throughout the country from state to state. So, just be very mindful of all of those rapid changes. Now, finally, for my third grab bag feature, it's going to include something really huge, right? There were so many, over 1,000 ICD-10 CM proposals. So all of these new codes will, in fact, probably be finalized in June, and again to be published in the October 1st, 2022 edition of the ICD-10 CM manual. Now, this particular proposal includes several of the newly announced dementia codes, which were previously discussed during the virtual March 2021 ICD-10 CM Coordination and Maintenance Committee meeting. Now, of course, as we know in this particular space, we already know that there are codes that exist for dementia without and with behavioral disturbances, but there continues to be a need for additional detail and additional specificity on other key associated disorders like psychotic disorders, mood disorders, and anxiety. Now, some of these new codes that are proposed include ICD-10 CM code F02.811, which is for dementia and other diseases classified elsewhere, unspecified severity with agitation. And there's a proposal for F02.A11 for dementia in other diseases classified elsewhere, mild with agitation. And there's another proposal for F02.B11 for dementia in other diseases classified elsewhere, moderate with agitation. And finally, there's a proposal for F02.C11 for dementia in other diseases classified elsewhere, severe with agitation. Now, I already discussed new COVID-19 vaccine status related codes in an earlier podcast episode, but these new proposed code changes also include a reissuance of these COVID-19 vaccine status related codes that were previously implemented on April 1st. So remember, these are for the codes Z28.310 for unvaccinated for COVID-19, and the code Z28.311 for partially vaccinated for COVID-19, and finally for code Z28.39 for other under immunization status. Now let's move on. There's also like more than 85 code additions that are related to head injuries being proposed in section S00 through S09 for injuries to the head. There's also a whopping 450 additions that are being proposed for Chapter 20 for external causes of morbidity. Now, let's move on. I find interesting there's also planned revisions again to the nervous system chapter that include replacing the word dementia in the codes G31.09 and G31.83 with the term neurocognitive disorder. Now, I thought interesting with another nervous system code, G93.3 for post-viral fatigue syndrome, that particular code needs more specificity, and they're going to be adding on 3 more codes if they're approved. And then, of course, the cardiovascular system chapter will expand as well if their proposals on codes are finalized. And then I also support more description changes for codes in the chapter for factors influencing health status, like in the code Z91.19 for patients' noncompliance with other medical treatment and regimen, with a code that more specifically describes the reason for noncompliance. And of course, there's many, many others, but those were my favorite highlights. And now it's time for my best practice tips in Trusty Tip. So I thought I'd provide my back to basics on Incident 2 billing requirements. Now, I honestly and truly believe this is one area of billing practice that continues to confuse everyone time and time again over the years. Now, first off, this construct exists in the office setting. And what it means is another qualified provider is performing or rendering the service instead of the physician. But that physician must be supervising the service as well. And there are other conditions that I detail next that must be met for their reimbursement for the practice to be gained at 100% of the physician fee schedule rather than at the 85% reimbursement rate for the qualified NPP. So it's all pretty complicated, but I'm going to do my best to dive in and disclose what one particular MAC or Medicare administrative contractor discloses on their webpage, and that would be for Novitas in the state of Maryland, in the state of Texas, but you can always look to your Noridian MAC if you're on the West Coast, or you can always look to your Palmetto GBA if you're in the Carolinas or Georgia, or you can always look to your First Coast service options if you happen to be in Florida. Look at NGS if you're here in Illinois or in New York. The choices are everywhere. All of the MACs provide this information on their web pages. So please pay attention to their web pages because they do outline specific qualifications and conditions that must be met for this incredibly complex construct to actually work and qualify to keep your reimbursements. Now, this is particular, again, like I said before, it's in the office setting. Qualifying Incident 2 services must meet the following guidelines. Now, the particular NPP must be employed by the same entity as the MD or the physician. Now, the person supervising and the person performing the service must be employed by the same entity. They may be an employee, a leased employee, or an independent contractor. They must also only be performed in the place of service 11 or POS 11, which is the physician's office. Now, the Incident 2 services must be integral, although incidental. And the patient must be an established patient with an established diagnosis. And the follow-up services rendered must be connected to the course of treatment that the physician planned at the initial service. Now note, Incident 2 billing does not apply to a new patient or a new problem for an established patient. That's the key feature there, which I've seen so many providers make mistakes on. Now, Incident 2 services furnished by staff of a substitute physician or a regular physician are covered, again, if they're furnished under the supervision of each. Now, let's talk about active participation and what does that mean? So it's going to be expected that the physician performs subsequent services of a frequency that reflect that active participation of the MD throughout the course of treatment for the patient for that specific problem. Now, they also provide a note here, and they give an example that a patient with chronic sinusitis will probably not have to be seen by the physician as often as a patient with congestive heart failure. But you must be documenting that physician, that MD is coming in throughout the patient's care. Now, let's move on and talk about direct supervision. What does that mean? Now, the physician must be present in the office suite and immediately available and able to provide assistance and direction throughout the time the service is performed. That is direct supervision. The supervising physician does not have to be in the same room, but they must be in the office or the clinic. Now, when the patient is seen in a group practice by a NPP, it is acceptable to have the NPP perform an incident to service when another physician of the group is in the suite and available for oversight as needed. Group members may provide cross coverage for each other, right? And incident to guidelines can be met in this circumstance. So that's what they disclose is direct supervision, must be met for incident 2. Now, they also provide examples of non-covered incident 2 services, and I see this all the time. So when the incident 2 service is not covered. So it's not covered when the NPP sees a new patient, right? An NPP cannot see a new patient, and the services are trying to be billed as incident 2, the physician. So that's a no-no. So you can't call that an incident 2 service. You should be billing that under the NPI of the nurse practitioner, right? So incident 2 does not apply in the following places of service, right? Like I said earlier, this has to be done in an office setting. So incident 2 criteria and constructs do not apply in the inpatient setting or in the outpatient setting or in nursing facilities. And a clinical social worker cannot be billing incident 2 services under their NPI number. And medical nutrition therapy and diabetes self-management training services are performed, right? Those are not considered incident 2. So they also move on and talk about diagnostic test benefits, right, that are set forth in our Social Security Act. That's going to be separate and distinct from the incident 2 benefit that's set forth in the Social Security Act. So diagnostic tests do not meet incident 2 requirements. Now, they also move on and talk about ambulance services. These are not covered, nor emergency medical technician services performed under a provider's telephone supervision. These are also not considered incident 2 services. And then, of course, services which have their own statutory benefit categories, these cannot be applied to the incident 2 construct as well. Then let's move on and talk about documentation, right? Also very important, and I've seen so many no-nos over time. Now, the patient's medical records must clearly indicate these following laundry list of items. So documentation must identify the individual who rendered the service. And then documentation must include and document the physician's presence in the office at the time of the service, right? Then you also must be indicating the supervision requirement is met. So you should document supervising physician's presence in the office suite. They were physically there. And then you must be showing the physician's initiation and continued involvement in treatment from record to record, right? So the physician has to have seen the patient first, not the NPP. And then you also have to show that the physician's involvement was throughout that particular problem that the patient was having during that course of treatment. And then the documentation must also show that the service is within the scope of practice of the non-physician practitioner, the NPP, as defined by state law. And then the documentation must also prove to be reasonable and necessary, right? The services must be proven in documentation to be reasonable and necessary. And then the non-physician practitioners acting as a scribe for the physician by writing notes into the medical record while the physician is personally performing the service, the medical record should clearly indicate this situation and be signed by both the scribe and the physician. And then finally, the documentation submitted to support billing the Incident to services must clearly link that the services of the NPP auxiliary staff to the services of the supervision of the physician. So you must be linking what the NPP is doing incident to the physician. Now, evidence of this link may include things like, obviously, a co-signature, right? Have your NPP have a signature and date as well, or legibly identify with those credentials, right? Comma MD, comma DO, comma NP, comma PA, etc. of both of those practitioner types, the NPP and the MD physician, right? So the medical record can disclose to a Medicare auditor in the end who is doing what portion of the work. And then documentation from the other dates of service, right? For example, that initial visit. That's so important. That establishes the link between the two providers. And remember that MDDO has to be the one who sees the patient first and perform all of that initial date of service. And then make sure the name and the professional designation of the person rendering the service is legible in the documentation of each service. So I hope this particular Back to Basics on Incident 2 proves to be helpful. Take a look at your Medicare Administrative Contractor, your MAC's web pages, like I stated earlier. They should all provide similar fact sheets or tools or education on the ins and outs of the complex criteria needed to satisfy the Incident 2 billing construct. Best practice should always be to document, right? We must be mindful that our provider's clinical documentation is capturing complete accuracy, that a new patient is being seen by the physician for the entire first visit, that history is being captured by the doctor, is being taken by the doctor, the exam is being performed by the doctor, and then the treatment and the plan of care, all of it at the first visit is being performed by the physician. Then it's those subsequent encounters when the problem is more established and the plan of care is established and is being followed under the direct supervision of the MD, then the Incident 2 guidelines are being followed. So a better, smarter approach is one that's proactive and starts by painting a clear, rich, and vibrant medical picture the first time, so your certified medical coder can then abstract codes with accuracy. And finally, I focus Season 5 Spark on clarity and focus. I want this 5th season Spark to be filled with the world's thought leaders, writers, artists, philosophers, everyone who inspires the need for clarity and focus in all that we do. So, in this week's inspiring quote in Spark is from Melinda Gates. A woman with a voice is, by definition, a strong woman. But the search to find that voice can be remarkably difficult. Absolutely true, right? I think this is an amazing quote that reminds us that there are times in our lives that we seek clarity and focus. This quote inspires us to gain clarity and focus day by day, week by week. This quote reminds us that our voices take a lifetime to develop. And at each chapter in our lives, our voices may resonate a little softer or a little bolder. Nonetheless, that voice is ours alone. I am happy Melinda Gates' spark still burns brightly in all of us today. So that wraps up today's episode. And as always, I appreciate you all diving into today with me. If you want more information from me, please go ahead and follow me on LinkedIn. I'll leave links to everything in the show notes below. Please continue having an amazing week, and please be safe and healthy. Thank you so much for listening in on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.